Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about otosclerosis. Now I'll be making this into a three-part series. Today is part 1 where I'll be discussing about what is otosclerosis and what is the etiopathogenesis behind it and what are the histological changes that we see in otosclerosis. In the next class I'll be discussing about the clinical features and investigations, how do we diagnose it, and lastly, in part 3, I'll be discussing about the treatment. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, what is otosclerosis? So, otosclerosis is one of those diseases that you really need to know about, and a common presentation, especially if you get a MCQ question, you'll see a middle aged female coming to you with conductive hearing loss, and sometimes even pregnancy can be mentioned. That will typically point towards otosclerosis. So let's try to understand what is it exactly. So this is a hereditary disorder of the bone metabolism of the otic capsule enchondral bone, and this is characterized typically by disordered resorption and deposition of bone. So basically, what is happening here is there is increased and pathologic bone remodeling. So there is increased deposition of bone as well as some bone pathological bone remodeling happening here. So the lesion that we'll see in here, the otosclerotic lesion, we see in the image here, usually involves the stapes footplate. This lesion typically consists of areas which have bone resorption by the osteoclasts, and then there is new bone formation by the osteoblasts, and this is accompanied by vascular proliferation and tissue stroma. So basically, it is a localized hereditary disorder of the bone metabolism involving the otic capsule. Now, let's talk a little bit about where do we see this disease. So, this is a disease which occupies about 0.5 to 1% of the population. And as I mentioned, usually the typical age that we see in is the middle age. So, hearing loss will usually start somewhere between 20 to 30 years of age. It is very rare before the age of 10 and after the age of 40. Coming to the sex predisposition, females are twice affected as males, and that is why the most common MCQ will mention a middle year aged female coming to you with bilateral conductive hearing loss. That is a typical MCQ question. Other than this, the races, we have seen that the white races are affected more than the black Americans, and this is also a very common disease amongst Indians, but very rare amongst Chinese and Japanese. And most of the times, this will be a bilateral presentation. You can also have unilateral presentation of this, but in 85% cases, we see bilateral conductive hearing loss being presented to you. So that's about some basic facts about otosclerosis. Now, before we go into the etiopathogenesis, let's try to know what are the different types of otosclerosis. So we can mainly classify into two types. There is clinical otosclerosis and histological otosclerosis, and clinical otosclerosis further can be divided into three. There is stapedial otosclerosis, there is cochlear otosclerosis, and then there is mixed type. So let's try to understand each one of these types. So, what is clinical otosclerosis? Clinical otosclerosis is when we are seeing lesions which are affecting the stapes, the stapedovestibular joint, or the round window membrane, and they end up in clinical signs and symptoms. They'll present to you with conductive hearing loss or even other types of hearing loss as well. Whereas in histological otosclerosis, you will not be seeing any clinical signs and symptoms, but when you examine the lesion, the area which is involved here, usually histologically, you will be seeing some lesions over there, but the patients will be asymptomatic. Now, in clinical otosclerosis, we can further divide it into three types. We have stapedial otosclerosis, cochlear, and mixed type. Now, stapedial otosclerosis is when the lesions, these otosclerotic lesions, are causing stapes fixation, and the most common A symptom over here would be the patients presenting to you with conductive hearing loss. Now, stapedial otosclerosis further can be of different types depending on where the lesion is and how is it involving it. So we know that the common site for otosclerotic lesions is the footplate of stapes. Now, if we divide it into 5 types, the first type is anterior focus. Now, let's look at the images over here. The first image marked A. This is what anterior focus lesions looks like. So here the lesion is starting just in front of the oval window, and this area is known as fistula antefenestrum. And this is the most common site of predilection in case of stapedial otosclerosis. Then coming to the image marked B, this is posterior focus. Here the lesion is starting behind the oval window. 3, let's look at the marked C image. Here we are seeing that the lesion is all around the margin of the stapes footplate. So this is known as the circumferential type. Next, looking at image D, you can see that the whole of the footplate has been involved over here, but the annular ligament, which is around the footplate, will be free. This type is known as the biscuit type. And the last type, the image marked E, this type is the obliterative type, where the lesion completely obliterates even the oval window niche. So, this is the different types of stapedial otosclerosis depending on the exact site of involvement and how it involves it. Now, in cochlear otosclerosis, the otosclerotic lesions do not affect the stapes or the stapediovestibular joint. Here, it will rather involve the cochlear endosteum. And the common mode of presentation here would be that the patient comes to you with a pure sensorineural hearing loss with no conductive element at all. Now, as we know that this is a very rare type, the most common type is the stapedial otosclerosis. And it might be very difficult to judge even because sometimes this is clubbed under the case of mixed otosclerosis as well. Now, there's another variant and another term that we need to know, and this term is malignant otosclerosis. Now, what does this mean? Is it really a malignancy? No, it is not. But it is rather, it has a feature that resembles malignancy, which is a rapid progression of the disease. So, malignant otosclerosis is this more severe type of cochlear otosclerosis, which starts very early in life and it progresses very rapidly. Hence, it is known as malignant otosclerosis. But this is a subtype of cochlear otosclerosis. And the third clinical type is mixed otosclerosis, where the lesions are not only involving the stapes but also the cochlea as well. Therefore, the presentation over here would be a mixed kind of hearing loss. Lastly, is the histologic otosclerosis, where we are seeing histopathological lesions which affect the stapes, the stapediovestibular joint, or even the cochlear endosteum. However, the patients remain asymptomatic during their life. They do not come to you with any of the symptoms that we see in clinical otosclerosis. And these lesions most often are discovered only post mortem, and this comprises about only 9 to 12% of all cases of otosclerosis. So these are the different types of otosclerosis. Our broad classification being clinical and histologic type being asymptomatic and only showing lesions. Whereas clinical type presents to you with certain signs and symptoms, and based on the site of involvement, we divide it into 3. We have the stapedial type, cochlear type, and mixed type. And the stapedial type further is divided into multiple types based on the exact site of involvement by the otosclerotic lesion. Now, next, let's try to understand what is the causes behind it. Now, we do not have an exact etiology for otosclerosis. However, there have been multiple factors which have been known to be a cause of this. Our first factor over here is the hereditary factor and the genetic predisposition. Why do we say this? This is because 50% of cases of otosclerotics have a positive family history, whereas the other 50% are sporadic. Now, amongst this 50% which have a positive family history, it has also been seen that this has been shown to have an autosomal dominant trait with an incomplete penetrance and variable expressivity. Now, what are some genes that have been associated with otosclerosis? The first gene that was identified with otosclerosis is the SERPINF1 gene. This gene has been associated in patients who have familial otosclerosis. This particular gene, it encodes for the pigment epithelium derived factor, which is a known regulator of bone density. Other genes are the COL1A1 gene, the TGFB1 gene, and the REL-N gene. Out of this, the COL1A1 gene and the REL-N gene have a sex-specific association with otosclerosis. And this is shown from the fact that the dominance of presentation is seen in females. So this is otosclerosis is twice as common in females than in males. These are all factors that are showing that there might be some component of heredity and genetic predisposition playing as an etiological factor in otosclerosis. Other than this, there are other factors like viral factors, for example. So, amongst viral factors, why do we think that there is a viral infection associated? It has been seen that some immunohistochemical evidence of measles virus protein and antigenicity has been seen in active otosclerotic lesions. Even we have seen increased expression of certain specific measles virus receptor CD46 isoforms in these lesions. And even these patients sometimes have been shown to have lower levels of anti measles virus IgG. Now, based on this, it has been hypothesized possibly there is a viral infection associated with causing otosclerosis. However, because this has not been completely proven, and then some other evidence has also come into view, which do not completely justify viral infection as a cause. What are these evidence? Complete measles virus RNA sequence has never been reported from these cases, and measles virus hypothesis also does not explain why otosclerosis is very rare among Africans, despite the fact that measles virus occurs very frequently in African children. So, this is actually not just a hypothesis that possibly a viral infection could be associated with otosclerosis. Other factors here are autoimmune disease. Sometimes it has been suggested that possibly otosclerosis represents a form of autoimmune disease with humoral immunity to the type 2 collagen. And certain cytokines have also been seen to be associated with otosclerosis, like the transforming growth factor beta 1 and the bone morphogenetic protein BMP. Even some hormonal factors could also be associated with it, because it has been seen that we see that hearing loss are sometimes initiated or made worse during the time of pregnancy, and deafness may sometimes increase during menopause. All of these pointing towards the fact maybe there is some hormonal factors behind this disease. And coming to the last point, and this is a very important MCQ question: what is the syndrome that is associated with otosclerosis? And the syndrome is known as Van der Hoef syndrome. Now, Van der Hoef syndrome is a triad of symptoms of osteogenetic imperfecta, otosclerosis, and blue sclera. Any MCQ question that puts three of these diseases together, you should be thinking about Van der Hoef syndrome. Here, the lesions of the otic capsule, which is seen in osteogenesis imperfecta, are histologically indistinguishable from that of otosclerosis, and both of them are happening because of genes encoding type 1 collagen. So that's about all of the etiological factors that could be possibly involved in causing otosclerosis. Now let's try to understand what is the pathogenesis of this disease. Now, all of these etiological factors, the hereditary factor, genetic factors, the viral factors, autoimmune factors, all of these combined, they affect the otic and the labyrinthine capsule. This leads to our first indication of the disease, which is enlargement of the perivascular space. This leads to two activities. One is there is bone absorption occurring by the osteoclasts, and secondly, new bone deposition by the osteocytes, which contain vascular spaces in the center. These two activities together lead to the deposition of more lamellar bone. And as more time passes, as more lamellar bone gets deposited, the mucoperiosteum of the middle ear starts to increase in thickness and it starts becoming more vascular because of neovascularization and vascular shunting. And this is when we see the characteristic sign on otoscopy, which is known as the Schwartz sign, also known as the flamingo pink sign, where we see a reddish hue through a translucent eardrum. I'll talk about this more in our second part of the series where I discuss the clinical features. Now, as the disease further keeps advancing, it leads to involvement of the bony labyrinth, leading to cochlear otosclerosis. If it involves the foot plate, it leads to stapedial otosclerosis. And lastly, it may also involve the round window. So, this is about the pathogenesis of otosclerosis. Next, let's talk about these lesions that we have been discussing, the otosclerotic lesions. If you look at the histology of it, what will we see? Coming to the gross pathology of it, the otosclerotic lesions usually appear chalky white, grayish, or yellow in color. Sometimes it may even be red in color because of its increased vascularity, where we talked about the Schwartz sign, which is seen because of increased vascularity. And if we see it is red in color, what it determines is the fact that the focus is active and rapidly progressing. Now, let's look at the microscopical histopathology over here. So, it has two phases. First is the early spongiotic phase, and second is the late sclerotic phase. What happens in early spongiotic phase is we see resorption of the bone around the blood vessels by the osteocytes. There is enlargement of the perivascular spaces. There is a widening of the vascular channels and dilatation of microcirculation. Then the collagen fibers near these are fragmented and they lose their normal striations. The resorbed bone now gets replaced by cellular fibrous connective tissue which contain osteoclast, giant cell, and vascular channels. And ground substance starts getting laid down by the osteoblast, and this is basophilic. And hence, when you stain it with H&E stain, it forms the blue mantles of Manassi. This is the typical name given to these basophilic material. Now, as within the focus itself, the existing vessels they start increasing in size as the surrounding bone starts getting absorbed, and so the focus is enlarging and reaching the surface mucosa of the middle ear. Vascular shunts form with submucosal vessels, resulting in hyperemia. This increased vascularity that is happening is seen as the reddish glow behind the tympanic membrane, and this is known as the Schwartz sign. When we see the Schwartz sign, what does it denote? It denotes that the otosclerotic lesion is in the active phase currently. So, this is about our first phase, which is the early spongiotic phase, and these are all the changes we see in it. Coming to the last phase is which is the late sclerotic phase. Here we see formation of dense sclerotic bone in the areas where there was bone resorption. Now here the new bone starts getting removed and replaced with osseous tissue which contain a lot of collagen fibers and very little ground substance. And here the deposition of lamellar bone starts getting laid down, and this forms the trabecular network along the margin of the mature osseous tissue. The earlier vascular channels that we were talking about in the earlier phase, they now get narrowed in this phase and leading to dense bony deposition. So these are our two phases of which is seen in the histology of all these lesions. Now these otosclerotic lesions they can be characterized histologically being either active or inactive depending on the stage of bone remodeling and growth tendencies that we are seeing. Now, if it was active lesions, what are the things that we will be seeing? Here we will be seeing spongy structure, immature osseous tissue with a lot of dilated vascular channels, and osteoclastic giant cells, and what I mentioned earlier, the blue mantles of Manasi. If you look at the image here, these are the blue mantles of Manasi, where a lot of cement substance is laid down, which stains blue with the H&E stain. So this is what an active lesion would look like. Now, the inactive lesion, they will represent the end stage of the otosclerotic bone transformation, and this will be characterized by solid, compact, lamellar mosaic-like tissue, which contain very tiny marrow spaces and small, infrequent blood vessels, and which have more of a fibrillar substance than cementum. And when we stain it, it stains out to be red in color. So, this is about our histopathology of otosclerosis. In my next class, I'll be talking about the clinical features and how are we going to diagnose the case of otosclerosis. See you in my next class.